I just want to say thank you very much, Alison, to begin with, just for hosting myself and Steph today, and for Steph for doing this alongside me. So just kind of wanted to highlight first and foremost that the revised mental health code of practice is actually scheduled to be launched on the 9th of July. Now, this session here is basically like an introduction awareness session to that. So we are currently in the process of developing an online package, training package that will sit on the HSC platform. As soon as that is ready, that's going to take about a period of time. As soon as that is ready, communication will be issued to trusts to make everyone aware of it. And at that stage, then obviously they can log on and do the training at their leisure. But in advance, just to let you know about some of the arrangements, the code will be launched and it will be available online to access from the 9th of July from the department website. And it does follow a period of consultation with trusts, with service user representatives, and with key stakeholders as well. So the initial drafts that went out, comments were taken into consideration and there were revisions made. So basically the 9th of July document, that will be based on that feedback. So in terms of kind of going forward, then where does it come from, and what is it all about? What is the background to it? So I suppose in terms of the revised code, in 2017, there have been many people on the call who will be aware of the deaths of Michael and Marjorie Caudry, who were killed in their home. And the person responsible for that death was an individual who had severe mental illness. There was an inquest led by Coroner Dugan, and what Coroner Dugan identified was basically that these deaths were preventable, and there was a series of omissions and missed opportunities that basically kind of led to devastating consequences. I suppose some of the key issues that she identified then in terms of kind of the learning within this was that the police, for example, did not use their legal powers under mental health law. There was generally a lack of understanding between the different agencies, HSC trusts and police, just in regards to general roles and responsibilities of each of them. General communication wasn't great, and there was inadequate information sharing, and again, decision making was generally fragmented, and there was kind of no shared risk assessment, failure to escalate concerns, and generally just inconsistent risk assessment and recording. So I suppose in terms of Coroner Dugan kind of obviously highlighted all these issues within the inquest, but alongside that, then there was learning from other ASAIs and reviews, which highlighted kind of similar kind of issues. So from that, a number of recommendations were made, not just in regards to the revision of the code of practice, but basically that's just one of the key recommendations that were made. So there was a number of documents that we had: the code of practice, the regional interagency protocol, and the GAID guidelines. And it was highlighted that the need to make sure there was clarity and consistency in application of the mental health order. And really together, recommended multi-agency training as well to reflect the emerging challenges and changes in our society since these documents had been written as well. So basically, that's where the code of practice was born from, the revisions. So primarily the need to clarify roles, responsibilities, thresholds, and to support defensible decision-making, to reduce the variation in practice across trusts, and again, to provide guidance in the interface between the Mental Health Order and the Mental Capacity Act. And again, training for frontline staff was a key issue in this, both for police officers, for trust staff, and for interagency training. Now, in terms of the overall recommendations, there's obviously a lot more detailed. There are ones that are specific to police, and police themselves have actually revised their whole training package as well. And there was other training identified, for example, for ED staff specifically. So that is something that we are also taking forward, and training will be made available to these ED staff as well, based on the recommendations that were made. One of the most important things, though, is the risk escalation frameworks that exist, and where there's concern, how do you escalate that, and how do you risk assess. So I'm going to pass you over to Steph Kerr, who is going to talk you through more of the nuances of what the actual changes are and what that might mean for practice for social workers.
Thank you so much, Charmaine. Hello, everybody. I recognize a lot of the names on the screen today. My name is Steph Kerr. I'm a service manager in the Belfast Trust, and my responsibilities include approved social work and all things Mental Capacity Act. So very glad to be part of this awareness session today. And I suppose I'll give you the context that I'm very much an operational manager and not a trainer, and probably then my approach to sharing information about the new mental health order code of practice will be extremely practical. So if that's not your vibe, I'm sorry. But as Charmaine said, she gave the context as to why we've ended up with a new mental health order code of practice. The current one aligns with the 1986 mental health order legislation. I think at the time, whenever the new code of practice was originally being introduced and discussed through the various working groups that Charmaine's referenced, and we had some queries, why have a new code of practice when we're due to stand down the mental health order for people age 16 and over, replace it with the Mental Capacity Act. And the reason for that is the Mental Capacity Act is some way off of being introduced in further forms than what it is at the minute with the deprivation of liberty safeguards. So with what had happened with Caudry, it was thought that it was really necessary to update the code of practice now, rather than just waiting several years until we have the Mental Capacity Act. So one of the really positive things about the new code of practice is that it consolidates the 1986 code of practice, which was not actually written in 1986, the guide to the order and the GAIN guidelines. I am an approved social worker and have developed great upper body strength through the number of documents that I would have carried around in an ASW bag. So the point of the new mental health order code of practice is that it provides that single rights-based reference for all professionals under the order. You could understand how something catastrophic could happen whenever everybody's working off of different documentation, and picking bits out of the various guides, codes, etc., that were available, whereas this revision introduces that single reference point. So the idea is that any professional, any interagency professional would be able to pick it up, find the part that they're looking for, and we're all singing from the same hymn sheet, essentially. It also introduces regionally agreed templates, for example, the alternative care plan that an approved social worker would use whenever they've completed an assessment under the order, and compulsory admission to hospital is not required. Every trust would use an alternative care plan, but they were all slightly different. And those sorts of regionally agreed templates have been discussed and explored with service user and carer groups as well. So there's been stakeholder involvement the whole way through. It also reaffirms the necessity of exploration of less restrictive alternatives, which is so important. Sometimes those less restrictive alternatives are not always available, but it's important that we're raising that they're not available, and if they were available, that we wouldn't be having to look at this really restrictive intervention for somebody. So it really encourages particularly approved social workers, but other professionals, to always explore less restrictive alternatives. And it provides clearer guidance on collaboration with the police and our ambulance colleagues, particularly around Articles 129 and 130, which, given the context that Charmaine has provided there around Caudry, you can see how important that is. It does introduce some changes to Article 130 procedures, both in terms of templates that need to be completed, which I'll talk about a bit more, but also in terms of what has kind of become the operational norm and what the legislation actually says. It clarifies the necessity and conditions for warrants, which for myself as the head of an ASW service is extremely welcome, and also clarifies thresholds for police intervention using a risk matrix, which we'll come to as well. So the core principles relevant to social workers, and these are principles that are relevant to social workers in all of the work that you ever do, so it won't be anything new, is respect for rights and dignity. Decisions must be lawful and proportionate. Person-centered and least restrictive practice. We must always explore alternatives. Participation and voice seeking and recording the person's views and involving advocacy where you can. I know it's a very stretched resource, it's not always possible. Interagency cooperation, and we find that approved social workers in instances of assessment under the mental health order have always coordinated the multidisciplinary process and have always done so really, really well. And it also comments on the MCA interface and the use of MCA where incapacity and is the risk as opposed to the risk being the risk as such. So for approved social workers, naturally the mental health order, while it impacts everybody, it impacts approved social workers and some interagency stakeholders more than some. So for approved social workers who are on the call today, and I know I've already met with my own in the Belfast Trust, so you'll already have been through this, but approved social workers remain the applicant for admission under Articles 4 and 5. So none of that changes. It stays the same, and it's the same application for admission for assessment. So the actual mental health order forms do not change with the code of practice. The independence from clinical direction is reinforced, and the importance that approved social workers bring to what can sometimes be a fairly medicalised process. Trust must ensure ASWs receive regular refresher training, which I know that everybody does. We all the ASW leads do talk about it. The mental health order forms remain the same, but any locally used templates will be replaced with regionally agreed ones. The most easy example to explain is the alternative care plan. And that's like what Charmaine was saying in terms of consistency and equity across the region in terms of documentation that's being used. Everything in practice is a lot safer if we have consistency. And ASW involvement under Article 130 has been clarified, and it does indicate a change in maybe what some people's current processes are.
Oops. We're a bit stuck here. There we go.
So for the coordination and collaboration with PSNI and NIAS for approved social workers, I think sometimes whenever we're doing our job under the mental health order, the assessment process can almost be less complex than multi-agency collaboration, which is certainly saying something. So ASWs continue to lead coordination where police or ambulance are involved, as we always have. The code consolidates the gain and regional guidance, as I said, into one unified process. For folks working in emergency departments, community teams, things like that, there's new handover and conveyance templates under Article 130 required. So at the minute, we're a bit lacking in sort of even data for Article 130 cases. And Article 130, for anyone that doesn't know, is a police power under the mental health order where a person who may present as mentally disordered in a public place can be taken to a place of safety. And the place of safety is generally speaking an emergency department. And at that point in time, they're assessed, which I'll speak to in a bit more detail. So a regionally agreed conveyance template has been developed, which would then be shared between the police and the emergency department staff, so that then we have the record of the ongoing input with the patient, which you can see from Charmaine's context and setting at the beginning is really important. There is a risk matrix then to be used when you're determining thresholds for police intervention and involvement, and we'll look at that in a few moments. Warrants need to be utilised, continue to be utilised. The same warrants that you would be used to under the mental health order, that doesn't change either, where appropriate and necessary. And escalation protocols have been established, which is super important. We now have an escalation protocol for approved social work services and other crisis services across trusts, where we have a clear escalation pathway for the police intervention, NIAS intervention, and in reverse, police and NIAS have that for approved social work services and emergency departments. So this is the first time we've really had that formalised, and it's a really, really welcome piece of work. If you're ever trying to access that, go through your approved social work lead in your trust. So police powers in terms of Article 129, 130, and again, Very practical. So Article 129, police may enter premises under warrant and remove a person to a place of safety for up to 48 hours. And Article 130 is where police may remove a person from a public place to a place of safety for up to 48 hours. The new code clarifies health professional involvement must occur early. So if a person is found in a public place and brought to a place of safety, then the police will want to contact and include the Trust's approved social work service early on in that process so that they are aware it might not end up being an assessment under the mental health order, but allow for earlier planning so that a person doesn't need to stay in an emergency department with police longer than necessary. Police powers are exceptional and only when necessary. A place of safety should normally be a health setting, and generally that's regionally agreed as emergency departments at this time. It is acknowledged and has been acknowledged through the various work streams that maybe emergency departments aren't always the best place of safety given the competing demands that we see in our emergency departments at the minute. And my understanding is trusts have been asked to consider other arrangements. But that's obviously a piece of work that takes time. And there's flow charts that have been developed and are in the mental health order code of practice, which detail the joint response procedures. So I'm going to speak about this very quickly instead of reading everything that's on that slide. You'll have the slides afterwards. It's basically what I've just said, where the ASW team will be alerted whenever a person has been subject to Article 130 so that appropriate planning can take place even if the assessment is not required. So that's something that I know I have colleagues in other trusts who already do that, and it works really, really well. We don't do it in the Belfast Trust, but we welcome the change. We don't really want our service users in emergency departments with police for longer than is necessary. And the decision for police to withdraw from a place of safety will be made collaboratively with Health and Social Care Trust staff, taking into account the associated risks to self and others. And then any disagreements on the withdrawal in those situations will be escalated through the escalation protocol that I've talked about. Again, the decision to step down Article 129 or 130 before the medical assessment and the ASW assessment under the orders taking place should be made by senior decision makers, and that would be quite unusual. It would be on the basis that there was a finding of no mental disorder. Typical example might be that a person might be under the influence, maybe late on a Saturday night in a public place, and then they're taken to hospital under Article 130 to a place of safety. But then as soon as a period of time has passed, they are well again and they can leave. It is asked in the code of practice that the medical practitioner assesses the patient within 4 hours of them arriving at the place of safety. So place of safety person lasts 48 hours, and that clock starts ticking as soon as you've entered the emergency department. I know that through the public consultation that there have been some perhaps challenges raised with meeting that 4 hours, but I suppose we're striving to meet the 4 hours, and it might not always be possible. Where it hasn't been possible, it's likely to be escalated through ongoing interagency meetings happening in trusts. If a medical practitioner determines the patient does not have a mental disorder, then Article 130 has to be stepped down, as no further powers to detain the patient would remain. And if it is stepped down, the patient has to be informed of that. So again, the medical assessment potentially supported by mental health liaison teams where relevant may conclude the patient does have a mental disorder. And in these situations, and again, I'm going to summarize this, and there'll be further training around this, as Charmaine said. Today's very much about awareness raising, and we look forward to receiving the training more specifically around this. But if the patient does have a mental disorder and is consenting to engage in a care and treatment plan appropriate to managing their needs and associated risks, there is a legal requirement for an ASW to interview the patient, even when the patient is consenting to the care and treatment. So that might be an operational change in terms of what happens at the minute. As part of development of the new mental health order code of practice, there was a legal tripartite formed with legal representatives from trusts, the Department of Health, the PSNI, and NIAS is the same as the trust with DLS. And that legal advice came back to say that an ASW interview should happen where there's a mental disorder, even if a person is consenting to the treatment. So that's something that we need to have a bit more of a think about in terms of our operating procedures. And if the patient does have a mental disorder, is not consenting to engage in services, then that generally comes then for a mental health order assessment, the same kind that we're all used to as approved social workers, where the MHOB, which again remains the same, is completed and a decision made as to whether or not compulsory admission may be required. And for the ASW response, a verbal response to Article 130 cases is expected within 1 hour. So that's something that the Trust ASW leads did agree that they could commit to, not necessarily being able to attend in person within 1 hour due to competing demands, ongoing bed pressures and things like that, but within ASW manager being able to provide that verbal response. That is the flow chart that talks through what I've just explained to you, so you can have a look at that another time. I think it's really useful to have these processes set out in the mental health order code of practice that you can reference. So there's one there, that's the Article 130, when the place of safety is a custody suite. So that's less usual, and that's if so that's the emergency department. You can skip on, Charmaine. Sometimes a patient will be brought to a custody suite instead of an emergency department because they cannot be managed in the emergency department usually, and it's much again the same process. For the approved social worker responsibilities during police powers, we're liaising with our interagency colleagues as soon as possible to coordinate the assessment, attending promptly, responding verbally by telephone within an hour, and that hour might be indicating when the actual approved social worker who'll be completing the assessment will be able to attend. I think the key thing there is communication. I think we all appreciate that we're all under pressure and we all have a lot of competing demands, but communication and clarity will be really key there in terms of other agencies' ability to plan their work as well, and recording, as we always do, all actions, timings, and rationale. As always, we retain copies of warrant forms where we've used them under Article 129, and they have been agreed to be uploaded to Epic via Media Manager. And the Article 130 template and joint handover record at the place of safety will sit at the place of safety and on the police records, as opposed to with ASW records. But if we're involved in an assessment under the order as a result of Article 130, we'd want a copy of that too. It'll have really key information that would help inform our MHOB. So this is just a slide, and again, it's just a quick reference slide for you whenever you have the slides on warrants. All these years of being an approved social worker, and I still have something that looks a bit like this in my approved social work folder for what warrant needs used when. So that's just something that you can easily and quickly reference, and those are the exact same arrangements and warrants that you would have had in the original mental health order and code of practice. Now, there has been some confusion, I think, or over warrants over maybe, I'd say, the last 2 years, and when warrants are required and when warrants are not required. So a really critical piece of work of the legal tripartite that I've referenced was clarifying when a warrant was required and when a warrant was not required. So essentially, to summarize this, when forms 2 and 3 are signed, that's an application for admission for assessment to hospital by an approved social worker and a GP. The police have power to remove that person to bring them to the hospital, but they don't have power of entry to the property. So that nuance is really important in terms of what the police can lawfully do. And you sort of think, well, they can remove them, so why can't they enter? And it's because the law doesn't say that they can enter. So there may be the necessity to get a warrant for the police to enter the property to remove the person to fulfill that power that they do have under the mental health order. Now, access to premises can be effected lawfully and without a warrant if the owner, co-owner, or co-occupier of the premises gives permission for entry, and a reasonable judgment is required when determining owner and occupier status as well. If it's our facility, for example, a care home or a day centre, then we can provide authority for and consent for access for police. So a really important thing will be making making sure that you clarify the consent for access to a property whenever you're asking for police involvement or NIAS involvement, any interagency. Clarify those consent arrangements for entry because that will be the point of challenge. So if you know what they are, that's really important. Now, slight quirk, if somebody's locked themselves in their bedroom, for example, in a care home that we own as the Belfast Trust, then they are within their bedroom and we still may need a warrant then for police to enter that bedroom because it is theirs. Whenever I delivered a similar presentation to my ASWs, they're always thinking, and we're asked sort of, if somebody has a private tenancy, and they're refusing access, can the landlord know that's their tenancy? So the same may be true in a supported living, for example, where somebody's holding a tenancy. So you're just clarifying those consent arrangements. And of course, before ever asking for a warrant from a lay magistrate, you need to be clear as to why you don't have consent to enter the property. It might be that the records indicate that continuously the service user who we may know well has not provided consent, but you should be trying first instead of utilizing those powers to gain access. You skip that, that says the same thing. So there's a lot of detail there on the warrants for you to look back on. So I think that to me that clarity is really welcome, because we kind of got to a place just accessing a person's private premises is really intrusive and it's something that the police take really, really seriously. So we did almost get to a place there where almost all cases where we're asking for support with conveyance were asked for a warrant, having those consent for entry arrangements and knowing what the specific issue is clarified is really, really critical. And the legal advice that came back around those challenges was agreed between all of the agencies who are represented in the legal tripartite. So everybody is on board. And sometimes it's about how you share the information. So those are just the best practice flow charts for the warrants that you can look at another time. This is kind of my last section and it's in terms of requesting PSNI assistance. So whenever we're requesting PSNI assistance, this has been clarified in the code of practice through use of a risk matrix. So the ASW will consult appropriately with staff from Trust, NAS and police to support effective decision making on all of the relevant information available, and each agency will complete and document a risk assessment detailing their opinion on the likelihood of the patient behaving in a violent or dangerous manner and share their risk assessments with other agencies involved. There's a lot of work ongoing at the minute, and I know Charmaine's going to touch on it shortly in relation to right care, right person and updating current data sharing agreements and things that we have between the different agencies. ASWs, NIAS, any other professionals, well, for any work that you're doing, this risk matrix would be a good point of reference for whenever you're requesting involvement. So you should request the assistance of police when the outcome of the risk assessment indicates is that the level for police involvement is identified in the risk matrix that we'll have on the next slide. Whenever police assistance is being requested, there is an Operation ASW code for you to use with call handlers. So the matrix is not intended to replace professional decision making and should be used only as an aid to inform decisions. So we need to use it to inform our decision as opposed to sticking extremely black and white to it. And every agency will be required to undertake their own risk assessment, with police and HSE staff disclosing any known risks and be clear about handover information. And you'll see the risk matrix here then on the next slides. And it is in the code of practice. So green, we always like green and we always like red. And then amber is whenever professional decision making becomes really critical. So your high risk cases there, you can see it's highlighted significant history of the medium risk factors that are in the amber part. And the green is sort of patients who you can encourage to go yourself, so you're not going to go to where and do the thing they need to do yourself. Amber is where I would anticipate, just as an approved social work lead, where we'll be having to have those high-level discussions with interagency colleagues to come to an agreed path forward. As with any risk matrix or any risk assessment, your green is almost straightforward, your red is almost straightforward, but your amber usually requires some additional discussion. And this is where it's going to be really important that we use our escalation protocols that have been developed and bring cases where we haven't been able to reach agreement to trust interagency meetings so that we can discuss, explore, and find the best path forward instead of falling into the trap of practices that aren't safe. Key differences, as I said, the language and terminology has been updated, and thank goodness for anybody who's familiar with the mental health order itself and the code of practice that accompanies it. The language and terminology is of its time. The new language and terminology is modern, rights-based, and inclusive. It's more human rights focused. It does have a section on the interface with the Mental Capacity Act. Very quickly on that, the mental health order should be used where it can be used, and the Mental Capacity Act will be used just sort of cheat sheet that I would use, having both services as where does the person need to go, and if the person needs to go to a psychiatric hospital, it's going to be the mental health order. Implementation of regionally agreed templates, as we discussed, police powers, and the necessity of police involvement has been clarified through the warrants, piece of work, and the risk matrix. And then there's going to be stronger oversight of the functions under the mental health order. For approved social workers specifically, who do a lot of work under mental health order, it's the adoption of those new templates, a greater focus, even greater focus on rights, capacity, and proportionality. The risk matrix being introduced for determining PSNI intervention thresholds, and certainly in the Belfast Trust, we've got a bit more work around that to support people with making those decisions. Formalised PSNI liaison using new templates, which is really, really crucial from the learning from Caudry, and then those changes to the Article 130 procedures that we discussed as well. And what we'll need to do then as trusts is update standard operating procedures, protocols, things like that that we have in place with the new code of practice after it's been launched in July. The local interagency groups have been established in trusts already, as far as I'm aware, in all trusts, and they are co-chaired with trusts in the PSNI. We had one just last week. There's representation from across key areas across the entirety of the trust, and those groups focus on challenges that are arising out of the mental health order, the Mental Capacity Act, and right care, right person. So those groups have been really, really critical. Certainly I found in the Belfast Trust in terms of that collaborative interagency working. The escalation protocol arrangements have already been shared and are already in place, which is really, really positive. And as I said, just sort of with a lot of sensitive personnel information, particularly for our PSNI colleagues, they are being held in a very confidential way. So if you ever do need to access that and you maybe aren't working in an approved social work team, something like that, go to your trust's approved social work lead and they will likely have the escalation protocol that can be utilised. Also, some senior managers and crisis response services and things might have that as well. We'll have ongoing audits where we'll be looking at proportionality and least restrictive practice. We need to make sure the mental health order is used appropriately and not to fill service delivery gaps where people are concerned about the risks, which you can see some creep in sometimes around that with placement breakdowns and things like that. And there will be dual form piloting recommended before the new templates are finalised. Obviously, everybody here who works in a trust knows that we're using Encompass. We can't just put pilot new forms on Encompass willy-nilly. They get really upset with us whenever we make changes to them. So there'll be an expectation of a piloting sort of process before we agree final drafts. And I think we can skip past that slide, Charmaine.
Thank you very much, Steph. Your mouth is probably dry from all that talking. So as Steph kind of has highlighted and alluded to kind of throughout kind of the presentation, we have right care, right person. Many of you will have heard of it. It's otherwise known as RCRP, basically what people are referring to. So the right care, right person, it's a policing and health partnership model that ensures people with health and social care needs are responded to by the most appropriate agency with the right skill set and not automatically police. In a review undertaken, police had found that there was a disproportionate amount of spent dealing with people in mental health crisis. And the argument being that they are not trained to do so, and they're not the most effective people that personnel that people need in a mental health crisis. And also, I suppose we know from experience that it can actually escalate concerns where there's police presence, but there is obviously always a role for them. So alongside, the cadre and the development of the new code, parallel to that, we are looking at implementation of right care, right person within Northern Ireland. It is already implemented in England. So at the minute, the department, we are engaging with our police colleagues, with trusts, key stakeholders, including the community and voluntary agencies, in regards to how we do that safely on a phased basis within Northern Ireland. So many of you might be aware that there are a number of subgroups which are looking at different aspects of what that's going to mean for practice. And the interagency forums are just one aspect of that, which we really, really want to strengthen. The interagency working, the collaboration, obviously, so that we can get better outcomes for our service users. So in terms of, well, what is the actual connection between the revised code and our CRP? Well, essentially, the new code, it embodies and underpins all the principles of our CRP. We're basically clarifying our health responsibilities and reducing inappropriate police involvement, but also strengthening that lawful rights-based responses to mental health crisis. And as Steph has talked there, particularly in regards to restrictive practices and that lawful, proportionate, accountable decision making. It also, as you can see from the risk matrix, that it sets clear thresholds for police involvement, very, very clear. And the police have assured us that where they need to be involved, they will still be involved. So, for example, in those high risk situations, or indeed where there is any indication of criminal activity. And again, the RCRP reduces incorporating everything within the revised code, reduces that ambiguity in regards to crisis decision making about whose role is what. Because sometimes things get lost in the middle of kind of those crisis situations when you respond to, particularly when those late night scenarios. And overall, it's about improved multi-agency coordination. I know that even from being within this role, our work and relationships with the police and with our NIAS colleagues and the ambulance have really, really improved over the past year. And it is basically all on that basis of shared understandings and communication, and again, the documentation and recording that goes along with that. What I can tell you is that the plans for the new online training will also incorporate right care, right person, particularly that first phase of implementation. Now, there is no set date at this moment in time in regards to when that will happen. We want to make sure that it is done safely. But communication obviously kind of will be happening over the course of time and agreed with all partners. So I'm going to stop sharing. Thank you very much for listening to us. And as I say, the code will be accessible on the department website from the 9th of July. So thank you very much.